Welcome to the 2023 Team Phenomenal Hope Research Town Hall. Tonight, we're going to cover a range of topics in rapid fire succession. Each presenter will speak for roughly 5 minutes on their topic. We will have a chance for Q&A at the end, so please use the Q&A function at the bottom of your screen. There's a Q&A button. You can just click that. A box will pop up, and you can type in your questions. So before we get started, I just want to share with you a little bit about Team Phenomenal Hope. For those of you who are new to us, we are a nonprofit organization founded in 2012. And our mission is to provide patient-centric programs and educational resources to those living with PH to improve their lives, bring them out of isolation, and also to contribute research dollars to find better treatments and a cure. We have so many exciting things going on at Team PH, and you can learn more about all of those things at teamph.org. Today, right now, I want to invite you to access the recordings of all of our PH Awareness Month webinars, including our current PH Research and Evolving Therapies webinar, and also our Inform PH Patients Tell All webinar. You can use the QR code on the rolling slides to access those, and you can also find the link to those at teamph.org. I also want to invite people living with PH and their caregivers to visit learnlivebreatheph.org, which is our educational resource website. This is to help those living with PH and their caregivers to navigate and manage pulmonary hypertension better. This website provides the latest scientific information about PH and is updated consistently by our medical advisory committee. This is an incredible resource. Please don't miss out on it. It's also a great place for providers to refer their patients as well. I would be remiss if I didn't take time to thank our generous sponsors. From the bottom of our hearts, thank you for helping us make PH Awareness Month special, not only for Team PH, but of course the whole community. So thank you to Janssen, CVS Specialty, Merck, Enzivant, and Arami Therapeutics. Just one last reminder, again, to please type your questions in the Q&A function at the bottom of your screen. And I think we're good. Let's get started. Okay, so jumping in here, our first speaker tonight is a dear, longtime friend of Team PH, and he has much experience in caregiving for a loved one who was living with PH. So please join me in welcoming Jonathan Broome. Jonathan, thank you so much for joining us tonight to speak on the topic, what to expect when a loved one is diagnosed.
Okay, so what to expect when a loved one is diagnosed with PH. So here's a brief part, our story. So the old timers among you know this. So I'm Jonathan, caregiver to Orna Levy. We met in high school. We waited till college to begin dating. And then she had weight and body issues for a long time. And she would rapidly gain and lose weight. And we decided to see doctors about it. And we saw a whole bunch of doctors with varying specialties, with all sorts of diagnoses, and very little positive effect came from it. Until finally, one night, one of our doctors said, I want you to go to UCLA tomorrow. And so January 9th, 2009, we went to the emergency department at UCLA. And what happened then might be familiar to a few of you in the audience. Suddenly, it's like drinking out of a fire hydrant with all these terms and things that all these medical people are saying, and none of it sticks. And we ran into all of this where it's like, what? And then finally, we got to start to learn. So the first 24 hours that we were there were like a total mind dump, or so it seemed from all the medical people. So then we finally began to learn, once we sort of got to step back a little bit, We got to learn we're at UCLA, a really good hospital, top-notch medical team, PH team. They're a teaching hospital. And while they're teaching the medical students, they're also trying to teach the patients and caregivers, which helped us a whole lot in the first 24, 48, 72 hours of what was going on. So what did we learn? She'd been finally diagnosed with something, with idiopathic pulmonary arterial hypertension. That's definitely a mouthful. Took us a few days to be able to repeat all those words in the right order. But over time, we learned a lot more about the disease and how to manage it from them. We're in the ICU this whole time, and we learned lots of things. So I want to say to anyone new as a caregiver, we learned priorities change, and you're going to learn that you can do a lot more than you had ever thought you could do before. We learned how to take an active participatory role in her medical care. We weren't just there while things happened. We were actively participating. Very important. And then things that we've learned, this is sort of to summarize what happened over the course of a number of years. Get to know your medical team. If you're new, get to know your medical team. Know your doctor's names, but know even more so the nurses and the nurse practitioners. And I think most people will happily admit the NPs are the lifeblood of the team. They keep things going smoothly. If you've got a good relationship with your NP, that's very valuable. Also, try to write down as much as you can as you're going through it so that you can refer to it later, so you can learn more. Also, remember, if you're the caregiver to the PHer, you're the second set of eyes and ears, and you're probably more able to focus on what's being said than the PHer is. So you need to be there. And then learn as much as you can so that if you ever need to speak during an emergency to handle an emergency situation where they can't speak or something, you can get out all the really key stuff in a calm and coherent manner. Nothing quite like getting that phone call when the person says, hey, this is LA Fire and Rescue. This person is down. What can you tell me? So you need to be able to give them like the elevator pitch in like 12 seconds. So, but the biggest thing that we learned with all of this stuff is it's a lot to learn. Don't expect to learn it all and have it make sense right away. If a medical team uses a term you don't understand and it seems important, ask them to backtrack a little bit and explain. If they jump to some conclusion that you didn't follow, ask them to explain. And I'll say most medical folks seem quite happy to explain things when you express an interest in learning it. More stuff, what I learned specifically as a caregiver to my wife, medication's easy. A lot of people seem to be very worried about, oh, there are lots of pills and things. No, medication ultimately is easy. You can and you will learn the names of it. You'll write stuff down. They'll write stuff down. You'll learn what it does. You'll know how to give it. Don't be scared of medication. That's easy. Then the more controversial one, medical procedures are easy. I say as the caregiver, of course, but planning and preparation will help you both get through the procedures that are needed. Find out what things are, what they do, what they hope to accomplish, schedule it, and what to be worried about and all, and then you'll get through it. The hardest part is really the insurance. Our first really big experience with insurance was what we learned to call viaggravation, which indeed I call the frustrating task of convincing your insurance company that yes, indeed, your wife really does need 270 tablets of Viagra every month. And then finally, as a caregiver, support them in every manner that they need, but don't swamp them or overly coddle them, or at least be sensitive to that. If they say, hey, I can do that myself, okay, duly noted, but what can I help you with? But they're gonna have pH for the duration. So you learn to do what you can do to make their having pH better. Lots of what else is. The big ones are ask for support, know that you can get support. Your NP is a great first place to ask about things. There could be a caseworker, a social worker as well. Varying people have varying effects with all that, so be it. Team PH has support groups. PHA, if you don't know about them, learn about them too. They have support groups too. And there's a lot going on Facebook. And then, in conclusion, over time, as a caregiver and as a patient, you're going to learn what you need to know as part of this. This is your new normal. Get used to it. You'll learn to navigate it and learn to live your best lives possible. And just to explain the two pictures, the first picture at the beginning was when we were dating. This picture, of course, is when we got married up at Lake Tahoe at an altitude of 6,000 feet, which she was told she couldn't do as a PHer. But over years and with medications and all that, we could do that. And we could go on to do other things. We went to the Caribbean, we went to Alaska, we went camping in Denali in Alaska, things like that. So live your best lives, and they can be pretty good lives. That's it that I have. Thank you.
Jonathan, thank you again for your time tonight. I know this information is vital to many out there who are new to caregiving for someone who has been diagnosed with PH. So really appreciate your time. Thank you.
Thank you.
All right, so up next, our friend Dr. Meghan Cirulis of Intermountain Health in Utah is going to talk PH classifications with us.
Thanks for having me. I am going to shift gears and talk a little bit about PH classification. And yes, I am out in Salt Lake City, Utah at Intermountain Health. So hopefully there's some of our patients and people we know on the call. So I'm going to talk about the classification scheme of pulmonary hypertension. And this is partially, well, mostly just to familiarize folks with the different terms that you might hear. So there's really two kind of classification schemes. First is the hemodynamic classification of pulmonary hypertension, which is essentially trying to identify where the problem is. So we use words like precapillary, postcapillary, and combined pre and postcapillary. And then there's the clinical classification of pulmonary hypertension, which is really what underlying thing has caused the problem. And this is when we talk about the WHO groups of pH. So this is a simplified scheme of the heart and lungs. So you've got the right side of the heart, and then we've sort of stretched it out. You've got the capillary bed here that's going through the lungs, and then that drains into the left side of the heart. And the right side of the heart collects the blue blood from the body, and then after it's oxygenated, the left side of the heart pumps that red blood out to the rest of the body. So the basic definition of pulmonary hypertension is just a mean pulmonary artery pressure. So that has to be obtained on a right heart cath, as you all know, of greater than 20 millimeters of mercury. And then this is where we talk about precapillary, postcapillary, and combined pre-post. So precapillary pulmonary hypertension is when the problem is really before the capillary bed. And we think about this in the small, what we call the arterioles of the pulmonary circulation. Postcapillary is a problem that's usually coming from the left side of the heart. And so there's blood backing up from the left side of the heart into the capillary bed and causing the pressure here in the pulmonary artery to be high. And then in the combined pre and post capillary pulmonary hypertension, that's when we have a mixture of both remodeling of the little blood vessels in the precapillary area, but also a high pressure coming from the left side of the heart. So these are the definitions of precapillary, isolated postcapillary, and combined pre and postcapillary. It's not really that important that you know the numbers per se, but I think just knowing when we talk about these different diagnoses, this is what we're using. So looking at the mean pulmonary artery pressure, the wedge pressure, and then also the pulmonary vascular resistance. And the combination of those three right heart cath numbers is how we sort of define these hemodynamic classifications. Okay. So then we'll jump into the clinical groups of pulmonary hypertension, which I think most people will be more familiar with. And this is a nice figure that was from the most recent European guidelines about pulmonary hypertension and highlights the different groups. So it also highlights the prevalence of these different groups. So I'll just go through them. But first wanted to talk about, I'll go through each of them, but I'm going to first talk about group 1, pulmonary arterial hypertension. And as Jonathan was mentioning, idiopathic PAH is a major subgroup in this group 1. And that's when we really don't know what's causing the pulmonary arterial hypertension. Also in the group 1 is heritable, associated with drugs and toxins. So this is where fen-phen pulmonary hypertension lives. And then also associated with other diseases like scleroderma, which is a connective tissue disease, in different infections, liver disease, or congenital heart disease. And then PVOD and pulmonary capillary hemangiomatosis are also within this group and quite rare, but they're also considered to be group 1. And PAH is a pre-capillary type of pulmonary hypertension. So then group 2 PH is PH associated with left heart disease, like we mentioned, and that is when you start having the post-capillary and the combined pre and post-capillary pulmonary hypertension hemodynamic classifications. PH associated with lung disease is can be associated with lots of different types of lung disease, so interstitial lung disease, COPD related to smoking, other causes of hypoxia or low oxygen levels can cause pulmonary hypertension. And then group 4 pulmonary hypertension is associated with pulmonary artery obstructions. And so the most familiar common cause of group 4 PH is CTEPH or chronic thromboembolic pulmonary hypertension, but other causes of pulmonary obstructions like cancers and things like that can block the pulmonary blood vessels can cause what we call group 4 PH. And then group 5 is this there's a bunch of different things that all kind of seem to classify. We don't exactly understand how they're causing precapillary or causing pulmonary hypertension. And that includes the hematologic disorders like myeloproliferative neoplasms, and then other systemic conditions. Okay, and that's all I have.
Thank you so much, Dr. Cirulis. I know that PVOD is an acronym that I'm now going to work on.
Yes.
This is so important, especially with the visuals for those who are new to the community. So thank you so much.
Of course. Thanks for having me.
All right, moving right along. So the holidays are already almost upon us. I don't think there's a better time to talk about traveling with PH, how to make things work, what to plan for, everything in between. Tonight we have Team PH's dear friend, advocate, volunteer, Julia Feitner, the traveling expert, and she's going to touch on some tools and tricks for us. Julia?
Awesome. Thank you for having me with you tonight. So I was diagnosed with PH 15 years ago, but I've had symptoms for 20 years now. At the point that I was diagnosed, I was so ill that 24 hours later, I was intubated in an ICU, and I had a sudden preemie newborn as well. When I came home from the hospital, I struggled to even get in the house, let alone be able to figure out how to travel outside my 4 walls to get to a grocery store, to get to church, or to get to the doctor's office across state, which was 3 hours away. So my family very quickly had to figure out how to travel with PH just to survive. And then as we were able to progress in our gumption and being able to do that, we began to figure out how to travel with PH to have fun as well. So here you'll see on the screen, I have given a talk with Team PH in the past, more than once actually, about how to travel with PH. Lots and lots of tips and tricks I've learned along the way. You can view the longer version of the talk at Team PH's YouTube page. Just go there and then search Traveling with PH, or you can use the QR code and access it easily that way. So let's jump in for a really quick overview. All right, so when you're traveling with PH, prior planning is the key. Anytime you leave your home, whether it's going to the grocery store, the dentist, across town, or even further, there are a couple main categories that I plan ahead of time. The first one is to research my destination and my route. Where is the closest parking for me to get to where I need to be inside that building? The fewer steps I take, the more energy I have for the rest of my day. Are there things available there that might help expand my energy, like wheelchairs? Lots of places had them available to borrow for free. What's the easiest walking path I can take? Often the easiest path for me is not the shortest distance between 2 points, because that may involve an incline. So perhaps I may look for a longer route that's actually easier on my body. Or I happen to be on IV meds. So in terms of the route, I will also make sure I know where bathrooms may be along the way, either in the buildings or along the road, in case tummy troubles happen to show up while I'm gone. The next thing that I will research for planning purposes is thinking about what oxygen and medical supplies I will be needing while I'm gone. How long will I be gone? How much will I need? And then I take extra, usually at least double. I have dropped pills in public down sinks where I am not about to retrieve that out. I always make sure I have extra. And then, as I mentioned, I am on IV meds. So I also make sure I have enough supplies with me so that if anything goes wrong, I can take care of it right there and quickly get back to doing what I want to be doing instead of dealing with my meds. The third thing to remember anytime you leave your home is to take care of you along the way. Figure out some contingency plans so that if there's a hiccup, it's only a hiccup and not a crisis for you. If there's an accident, will paramedics know any information about you, your meds, or the conditions you have? If you're delayed and you don't get home at the time you're expecting, are there medications that are due shortly after or due the next day, perhaps, if it's a long delay, so that you could take this extra with you? And then the delay is either a spontaneous jaunt in a different direction or a hiccup, and it's not crisis terrifying mode for you. Another thing to do to take care of yourself along the way is to stop, rest, and just catch your breath. So often we are pushing ourselves to the limit of what our bodies can handle that we forget the importance of just pausing and breathing in the moment, letting all of our pressures come down, our oxygen come back up, and then progressing with our day. And then finally, in that category, if you happen to be on a sodium or a fluid restriction like I am, it's important to sometimes treat yourself, yes, because we're living, we're going to thrive, not just survive. But take a look at that pizza and decide, is it worth it? I know how I will feel after that. Is it actually worth it today? Make sure you take care of yourself. And then finally, don't let pride stand in your way. If you need help, ask. Most people are lovely and quick to lend a hand. And if they're not, well, bless them anyway and move on with your day. But at least you have asked. Now, in terms of a longer trip outside of just my immediate town, other things that we have learned, I include in the much longer version of this talk. And for a longer trip, it includes lots and lots of tips and tricks regarding hotels, airlines, and how to coordinate with your PH doctors and your specialty pharmacies before your trip, and even if necessary, while on your trip. What we've learned is that if there's a will, there's a way. All it takes is creativity and prior planning. So once more, if you wanted to check out some of the other information that I had to share based on our experiences, then my screen's not changing. There we are. Then go to the Team Phenomenal Hope's YouTube page and just search for Traveling with PH, and you'll see the longer rendition of this, or you can use the easy to use QR code and it will take you there as well. And that's all I have for today. Thank you.
Julia, it's always a pleasure to get to spend some time with you. Thank you so much. This is such a hot topic, and it's also fun because it helps our community to focus more on enjoying their time traveling. So thank you again.
Absolutely. My pleasure.
So next up, we're delighted to have respiratory therapist Tonya Zeiger of the Mayo Clinic in Florida talk to us about oxygen therapy for PH. Tonya, thanks so much for joining us.
Well, thank you for having me, Katie. I would like to tail on to the travel discussion in the fact that another big concern is making sure that you have appropriate oxygen. Some of the more challenging things that we deal with is, of course, the mass marketing of the portable oxygen concentrator. While it's fantastic for those people that it works for, in some cases, it's just not feasible for our patients to use it. One of my favorite things to remind my patients is that none of the medications that you're using can actually work appropriately if your oxygen levels are low. So be aware, make sure you have a pulse oximeter. The pulse oximeter is a tool. It literally is something that you can put on your finger, glance at, and say, okay, I am okay. I tell all of my patients that that is one of the most important tools that you can have in your pocket. We like for your oxygen level to be above 90%. If your oxygen level drops below 90%, your body's automatic response is to constrict your blood vessels. When it constricts your blood vessels, it's doing the exact opposite of what your medicines are trying to do. So be aware. Make sure that you're trying to keep that oxygen level up at all times. Even if your oxygen level is dropping for, I've had people say, oh, it only drops for 30 seconds. That 30 seconds is enough if it happens multiple times during the day to make your pulmonary hypertension actually a little bit worse. So some of the other challenges we have is that patients, when your oxygen script changes, you've got to make sure that your oxygen testing, as well as your face-to-face with your physician and your prescription, are all done within a 30-day period. That's a very short time frame if you're new to oxygen. So it's important that you know that you need to call your insurance company, find out who your durable medical equipment provider is. As we talked about the pulse oximetry, I'm sure that many of you are aware that most of them are finger probes. It actually uses an infrared light, to look through your red blood cell. It knows the weight of an empty red blood cell, and it basically extrapolates so that it can tell you how much gas is attached to that red blood cell. So when you look at that and it says 96%, it means that you have 96% gas attached to your red blood cells. The reason that's important is that if you're around a smoker, the carbon monoxide that they exhale or that you inhale with a cigarette actually has about 220 times the capacity to jump onto that red blood cell as oxygen. So effectively, it kind of fills up all the seats on the bus, and there's no other seats there that are available for the oxygen. So it's important for you to kind of stay away from that situation. In basic, I guess to go into basics, the majority of my day is spent a lot of times with patients and just going through and explaining to them the portable oxygen concentrator versus oxygen. If you require more than 3 or 4 liters of oxygen, unfortunately, the portable oxygen concentrator cannot provide that for you. They will provide a pulse flow of oxygen. Those numbers on the pulse oxygen equipment actually don't correspond to liters per minute, which most medical institutions actually titrate you to. What they do correspond to is how many mLs or cc's per puff that machine is giving. Again, on the unfortunate side, there's about 32, I believe, portable oxygen concentrators. And since they're not mandated to align with each other, those numbers don't actually correspond to any other equipment. In other words, you could be looking at one portable concentrator and number 1 would be giving you 16 mLs per puff. And you look at the second portable oxygen concentrator and that one's giving you, with a number 1, 32 mLs per puff. None of that really matters as long as your oxygen level stays above 90%. What I tell patients all the time is if you would like to try a portable concentrator, do not buy from certain companies that are national that have a huge sales force and don't have return policies. You want to buy and from a company and make sure that you have a 30-day return policy. It's really, really imperative that you make sure you have what you need. The second part is if you do have any equipment that you sleep with, a CPAP, a BiPAP, a portable ventilator, it's important that whatever oxygen you are traveling with or that you are using at night is a continuous flow. If it is not continuous flow, it's going to break that cycle, and both machines are going to alarm all night. So it's really important to kind of know what you're using. Again, take home message here, that the pulse flow is not the same as continuous flow, and that you definitely want to make sure you prepare if you're traveling. And lastly, if you are purchasing equipment, you want to make sure that you have a 30-day return or some return policy that you can return it if it doesn't work. That's all I have.
Yes, thank you so much. Things like the return policy, I would have never thought to think about. So thank you. This is so valuable. Really appreciate your time tonight. Maybe a deep dive on this topic in the future?
Absolutely. Absolutely.
Right.
There's so much to cover.
Yes, agreed.
Awesome.
Right. Well, coming up, I'm so happy to introduce nurse practitioner Jenn Keeley of Allegheny Health, and our original stomping grounds where Team PH was founded in Pittsburgh. Jenn, I always look forward to our time with you. Thank you for joining us again this year for Awareness Month, and for making time to talk about PH medications and their pathways.
Thank you so much, Katie. And it's so nice to be here on this wonderful evening. And I have to say, no matter, what we share, there's always learning points that everybody can learn from other people. So don't ever hesitate to join a support group or a learning opportunity such as these that Team Phenomenal Hope offers. So as Katie said, I'm a nurse practitioner. I am in Pittsburgh, Pennsylvania at Allegheny General Hospital. And thank you again for allowing me to be here with you. So I want to talk about medications and pathways. And what's so intriguing about pulmonary arterial hypertension and the classifications that Dr. Cirulis had reviewed is that we have identified 3 very distinct pathways, and medications that we treat pulmonary arterial hypertension with come from these very distinct pathways. The first pathway I want to talk about is the prostacyclin pathway. And this is in the PAH patient, these substances such as prostacyclin are down titrated in PAH patients. In other words, they don't produce enough prostacyclin. And that's unfortunate because prostacyclin, and particularly at the very bottom of that pathway, you see the little molecule called cyclic AMP, CAMP, is the most potent vasodilator that we have in the body. And when PAH patients present, we know that they are lacking prostacyclins. So the medications that we have in this pathway actually improve the substance of prostacyclin, therefore promoting vasodilatation and decreasing vasoconstriction. The more that the artery in the pulmonary system dilates, the more easy that the blood can flow through these very narrowed fibrotic vessels. So improving prostacyclin improves vasodilatation and improves blood flow in the pulmonary system. The second pathway is in orange there, and it's the nitric oxide, cyclic GMP, and soluble guanylate cyclase pathway. Say that 10 times and you get the prize for the night. But the nitric oxide pathway, again, is a substance. Nitric oxide is a substance that is plateaus in patients with pulmonary arterial hypertension or is not produced enough, therefore causing vasoconstriction. So in this pathway, the drugs that work in this pathway improve vasodilatation by earmarking that nitric oxide pathway. And then right below that nitric oxide molecule is a soluble guanylate cyclase. And there is a medication that works by with or without nitric oxide by stimulating that molecule. Ultimately, again, getting down to that cGMP. Off to the left of that pathway, you see where PDE5 comes into play in this pathway. And PDE5 is an enzyme that actually breaks up the pathway to cyclic GMP. So the drugs that we have to treat in this pathway, actually inhibit that enzyme, allowing for more cyclic GMP, more vasodilatation, and improvement in symptoms of our PAH patients. And then to the far right there in purple is the endothelin pathway. And unfortunately, PAH patients have more endothelin than non-PAH patients. And endothelin is the most potent vasoconstrictor, so narrowing pulmonary artery diameters. And so what we want to do with the endothelin pathway and medications is actually antagonize and down titrate the endothelin to prevent vasoconstriction and very importantly, proliferation. And it's the proliferation of these cells that cause the pulmonary arteries to actually narrow and proliferate with this gummy substance that can fill the arteries and cause worsening symptoms. So again, just to reiterate, it is in the PAH patient, we have discovered that these pathways are somewhat imbalanced in PAH patients. And so we have developed medications over the years. The first one, Flolan, being FDA approved 28 years ago, by the way. So I'm giving you a 5-minute presentation over a timeline of about 28 years. So if we, again, look at these pathways, we can see the drugs that actually treat these pathways or these substance imbalances. So the endothelin pathway, we have treatments that are called endothelin receptor antagonists. And so an antagonist is something that fights against it. And we call these for short, you may have heard it, ERAs, or endothelin receptor antagonists. These are the drugs that you see right below that we have FDA approved therapies for. There are 3 of them, and they are oral therapies. Many of these drugs, as you may know, are associated with a mitigation program because they can be toxic to the embryo and fetus. And so we have to make sure that we test all women of childbearing age with pregnancy tests. The second pathway, the nitric oxide pathway, contains treatments, just as we had talked about in the previous slide, PDE5 inhibitors. So we want to inhibit that enzyme to produce more cyclic GMP. These are PDE5 inhibitors for short. And then SGCs, or soluble guanylate cyclase stimulators. These are your sildenafils, your tadalafils, and your riociguats. Again, these are oral therapies. And then the last pathway is called the prostacyclin pathway. And again, these are prostacyclins that promote vasodilatation by providing either prostacyclin substances to the body, or prostacyclin receptor agonists, or prostacyclins that favor the IP receptor. And the really interesting part about this pathway is you can see there are all forms of medications that are contained in this pathway: oral, inhaled, DPI stands for dry powdered inhaler, and oftentimes in parenteral form, or those that can be delivered underneath the skin or subcutaneously, or even directly into the bloodstream via IV. And so we've come a long way. You can see the armamentarium of drugs that we have to treat these particular pathways. One drug treats one pathway. I often get asked, do we have a drug that can treat all three pathways? And the answer to that is no, not yet. We also have exciting things upcoming where we have some drugs that are in clinical trial that are actually outside of these three pulmonary vasodilator pathways. So really exciting things to come. I just want to briefly mention some other therapies. Calcium channel blockers are medications that have been around for a very long time. We use these as anti-anginals in the cardiology world. We use these as antihypertensives to bring down high blood pressure. But in the PAH world, we use these as vasodilators. When you have your right heart catheterization initially, they test to see if you are one of those very, very, very rare patients that can be treated with calcium channel blockers alone. The next one is blood thinners to prevent clot. That environment in that fibrotic and proliferative inner lining of the pulmonary artery is oftentimes in some patients very ripe for clots to form. And so we want to treat those patients with blood thinners. Diuretics are water pills. Again, when the right heart starts to decompensate, there's a lot of organs in the body, such as the liver and the lungs, that can fill with that extra cardiac fluid. And so we use diuretics to release that fluid volume from your body. Digoxin is a drug, old drug that's been around, FDA approved since the 1950s, that actually helps the right heart beat stronger and slower so that it can be more effective when you have pulmonary arterial hypertension. And of course, as Julia and Tonya had talked about, oxygen is a very, very important actual medication because when you don't have enough oxygen for various reasons in the body, it actually vasoconstricts. And that's just the opposite of what we want to happen in the pulmonary vasculature. So oxygen, I often tell my patients, is a medicine. And oftentimes I write it down on a prescription, and it is a very good vasodilator in PAH patients when they don't have enough oxygen. So that's in a nutshell. It's a lot of information in just 5 or 10 minutes here. Save your questions if you have anything for the end of the talk, and I'm happy to answer them. Thank you so much.
Yeah, I know I have questions that I'm putting in the Q&A. So Jenn, thank you so much. I know that this particular topic, I always welcome a refresher personally. So I know that this is much appreciated. Thank you so much. All right, next we're going to jump into medication resources that are available to the community. Jordin Rice, PH nurse at National Jewish Hospital in Denver, is going to lead us. Jordin, it's great to have you back with us so soon. You spoke with our support group meeting in July. We're just so grateful to have you again.
Always happy to be here. I see a lot of familiar names and faces here today. So thanks for joining. There's a lot of fantastic speakers. So you're definitely, I'm lucky to be here. Today I'm talking about medication affordability. This is all about financial ability to afford medications, which is arguably the worst part about having pulmonary hypertension. It's definitely a very stressful part of it. And I wanted to talk a little bit about that today. Insurance is often not enough with these very special and rare medications that Jenn was just talking about. There are very few approved therapies for pulmonary hypertension, about 15, and each of them comes at a pretty big cost. I just wanted to talk a little bit today about some of these medications and how we can actually help you afford them as a doctor's office. So the first set of affordability is wholesale pharmaceutical cards. Many of you might know about these, but Single Care and GoodRx are a great way to afford medications that are available at a retail pharmacy. And when I talk about retail pharmacies, I mean, you know, the CVS on the corner of the street, King Soopers, Costco pharmacy. All of these are pharmacies that you could use a card like this at. It will make your medication run without insurance, so it is completely separate from your insurance. The only thing about these is that they're not always covered appropriately. Some retail pharmacies are much more expensive than others. For example, Walgreens is often a lot more expensive for tadalafil than CVS or Costco. This always fluctuates. You can check the websites of these drug cards and see that in your local area. The one thing about these cards is that they don't cover other specialty medications like ambrisentan, Tyvaso, treprostinil. All of these medications have to be through a specialty copay assistance program, and I'm going to go through those next. So other specialty medications, anything you receive via the mail, because they are more rare, they're going to have to go through a separate financial assistance program. One thing I always recommend to patients and even providers is fundfinder.com. That is a great website to figure out what copay assistance programs are open. There are nonprofit copay assistance programs, and then there are drug manufacturer assistance programs. Both of these we can have patients apply to. You always have to apply for nonprofits first. If any nonprofit is open, such as Healthwell, the Assistance Fund, Good Days, those are all going to have to be initiated first. Those applications would have to be initiated first before applying to manufacturer assistance funds. If you have questions about it, go to fundfinder.com. You'll be able to look at every assistance fund that is open. That's a nonprofit assistance fund. Right now, I believe there are no nonprofits that are currently open. Each copay assistance program does have income limitations. The only copay assistance program that doesn't have income limitations is the pharmaceutical drug cards like GoodRx and Single Care. Manufacturer assistance programs are what we use a lot of the times when the nonprofits are not open. These are for the brand name medication. So Adempas, Letairis, Tyvaso, Opsumit, all of these probably ring bells. Each manufacturer, since these medications are very rare, has to create some type of affordability program for patients. These medications, even with a prior authorization, meaning your insurance approves it, can still be extremely expensive. With a prior auth, with your insurance saying this is okay for you to take, they can sometimes still be several $1,000s, and nobody can afford that. Your doctor can't afford that. I can't afford that. We don't expect you to afford that. So these medication assistance programs are really important in order to get your medication at a very affordable cost, usually around $5 or free. So some of these applications, Letairis, they have the LEAP program. Any type of United Therapeutics product, there's UT Assist. Janssen has multiple patient assistance programs, and then also Bayer has a great assistance program as well. There's a few things to know about this, though. You can't apply until the nonprofits are closed, which is what I mentioned before, and there are also income limitations. They're listed on each website for the drug company. So if you go to the drug company's website, you can actually look that up yourself, but please don't be afraid to ask your provider about what is right for you. This is an extremely confusing thing to navigate by yourself. We never expect you to navigate it by yourself. There's a few more things to learn. There are basically three different groups of people: those who have commercial plans, those who have government plans such as Medicare, Medicaid, and then uninsured patients. Commercial plans are normal insurance that you get through your workplace, like Cigna, Anthem, Aetna, Kaiser. All of these are commercial plans. You can also get supplement plans with government plans, but then we get into this nitty-gritty of things that get kind of convoluted. So I would definitely ask for help when you start discovering which plan's right for you. Some key points about talking about all these different groups of people: uninsured, government plans, commercial plans. We can always get coverage for your medication, or at least try to get coverage for your medication as long as your income allows. And the income limits can be quite high. So for most patients, it's quite attainable. Your doctors are not insurance experts. I am not an insurance expert. I don't know the perfect plan for somebody with PH, and that can change from a year-to-year basis. The most important thing is to let your doctor know if insurance is a concern for you. You can talk to them up front about it, and we can help navigate that as nurses or in the medical team.
know who pays for your medications and when your coverage expires. I've had so many people that reach out to me after their nonprofit plan or Janssen plan has expired. And then they're kind of in this pickle where they're running out of medication, and that can be really, really scary. So know who's funded your medication in the past and know when that expires so you can be proactive in the future. And then always let your provider know of any insurance changes. If you have a change of your insurance plan, it's really important to let us know. We can get a head start in terms of getting everything ready for the prior authorization when your insurance expires. So that is pretty much all I have today about the affordability with medications. Thank you so much for letting me present about that, and I'm happy to answer any questions you have.
Jordin, thanks so much for touching on this topic. It's so overwhelming, like you said, to navigate all of this on top of managing a chronic illness. So I hope we can talk more about this subject soon.
It'd be my pleasure.
Looking forward to it. So next, everyone, I'd like to introduce you guys to nurse practitioner Martha Kingman of UT Southwestern Medical Center. Tonight, she'll cover swelling management, which is something that we at Team PH frequently receive questions about. So Martha, we're so grateful for your time tonight.
We're going to talk about swelling in pulmonary hypertension, which is a very common occurrence in pulmonary hypertension patients. As healthcare providers, we often call this volume overload or fluid overload. And again, happens quite often. Most patients will experience it various times through the disease process. Sometimes it just happens for no apparent reason. Other times it could be because there's been an excess sodium intake. I think there was a mention of, is the pizza worth it? Sometimes it isn't, and it can end up and cause you some swelling. Sometimes it can be an indication that the disease is progressing, so we always look into that. There are medications that we use that can also contribute to swelling. Those include the ERAs and the calcium channel blockers that Jennifer mentioned earlier. And sometimes patients will just, we all get busy and can miss some of the doses of their diuretics. The diuretics means fluid, pills that remove fluid. You might call them water pills. We call them diuretics. Maybe you've run out of the diuretics and it's been a few days and now you have swelling. This is the outpatient management plan, and outpatient meaning we're trying to keep patients out of the hospital. So what we ask our patients to do, especially those patients who tend to develop swelling, is to weigh every day. And it's a very specific weighing process where you weigh in the morning after you've gone to the bathroom, after you've urinated, preferably with no clothes on and without having eaten or drank anything. So just get up, take your weight and write it down, record it, because it's really hard to remember. I don't think I can remember what my weight was yesterday specifically. So you got to write it down. And this is the way that we pick up on swelling even before patients can see it sometimes, because the first thing that'll happen when you're swelling is the weight will start going up. We tell our patients if your weight goes up 2 to 3 pounds overnight, or certainly 5 pounds in a week, let your pulmonary hypertension team know about that so that they can address it, increase those diuretics, and really nip it in the bud before it becomes more of a problem. Also, monitor yourself for swelling in your legs, or some patients get swelling in their abdomens. Some get both, some get one or the other. It just kind of varies from patient to patient. But usually when you have swelling and weight gain and volume overload, you'll feel more short of breath as well. And then as we get the fluid off, the breathing tends to get better. So Jennifer mentioned sodium restriction, and so did Julie about the pizza. And it's really important. We ask our patients to try to limit the sodium intake to 2,000 milligrams, which is 2 grams or less every day. And to really be careful about this requires looking at the labels on everything that you're eating, looking how much sodium is in it, recording it, and seeing if you're making sure you're keeping it under 2,000 milligrams a day. In general, things that you want to be really wary of or stay away from are processed foods, things that are canned, like soups, frozen dinners. Those things all use a lot of sodium to preserve them, and they can cause a lot of fluid retention. Eating out is difficult, especially fast food restaurants. They load everything up with sodium to make it taste better and can be really a problem for patients with pulmonary hypertension. Also, if you're admitted to a hospital that maybe isn't familiar with pulmonary hypertension, not where your pulmonary hypertension team practices, they may tend to give you a lot of IV fluids. So we tell our patients, if you're going to a hospital somewhere else, they want to give you a bunch of IV fluids, tell them to call us. We don't want that to happen, because when it does, patients end up volume overloaded. It can be a problem. Now, some of our patients who really have recurrent episodes of volume overload and really struggle with this, we also ask them to restrict their fluid intake. So your pulmonary hypertension doctor may put you on a fluid restriction. When we do that, it's usually 2 liters per day. And we ask patients not to drink more than 2 liters. That's the same as 64 ounces or 8 measuring cups, however you want to think about it. It includes everything that pours. So not just water, but everything together. Want to keep that under 64 ounces if you're somebody who has problems with fluid retention. There are some usually minor risks of using these water pills or these diuretics. And one is that it can affect the kidneys in some cases and can worsen kidney function. Usually that's temporarily, and we can decrease the diuretics and do some other things and get the kidneys happy again. We do ask patients to avoid using NSAIDs. Those are medications like ibuprofen, naproxen, Aleve, those kind of anti-inflammatory medications. If you're taking those at the same time you're taking these water pills, it can be more likely to hurt your kidney. So we do recommend avoiding those. And as all of you, I'm sure, are aware, frequent blood tests in this patient population, because we want to make sure that we're following that kidney function over time really closely. In rare occasions, if we overuse too much diuretics, we might cause low blood pressure. That's pretty rare. But what is common is low potassium levels. When we give these diuretics, these water pills, we're making you pee a lot more. And when you pee more, you lose potassium. So low potassium levels are very common. And because of that, we generally will give either potassium pills to replace that potassium or medications that help keep the potassium level up. We'll talk about those in just a second. And then magnesium levels can also become low with the use of diuretics. These are the different categories of diuretics. The most commonly used ones are called loop diuretics. Those are the lasix, or furosemide, Bumex, torsemide. Then there's thiazide diuretics like hydrochlorothiazide. Metolazone is a very, very potent diuretic that we use just usually on occasion. And then the aldactone antagonists are medications that are diuretics. They help remove fluid, and they also have this benefit of keeping the potassium level from getting too low. So we'll often use a loop diuretic in addition to one of these aldosterone antagonists, which is usually spironolactone. When patients are retaining a lot of fluid, we might increase the dose of diuretics that they're on. Sometimes we have to add another diuretic. Sometimes we'll switch to a different category, just different things that we can do to try to prevent hospitalization. And if all of that fails, then we have to admit patients occasionally to the hospital for what we call IV diuretics or intravenous diuretics. That can happen for various reasons. When someone's admitted with severe volume overload, then we look for precipitating things that may be going on. Maybe there's an infection that caused it. Maybe it's worsening pulmonary hypertension. But when you're in the hospital and getting these IV diuretics, you get regular daily lab work, so we can watch the kidneys very carefully. And then once all the fluid's removed, then we send you home. And it's important when you're discharged from the hospital to make sure you know what your dose of your diuretic is supposed to be when you go home, because that's often changed from what it was before you went in the hospital. Also, make sure you have a follow-up visit scheduled with the pulmonary hypertension team. And then when you get home, go back to your daily weighing, as we talked about earlier. So that ends my presentation on swelling. And I'm also happy to answer questions at the end.
Martha, thank you so much. And like our other topics tonight, I think a deep dive into this would be really helpful for our community. So it'd be a great excuse to have you back.
Okay, thanks. I'd be happy to.
Great. Thanks again.
Thank you.
All right, now we're going to welcome Dr. Jean Elwing of the University of Cincinnati to talk about exercise with pH. Dr. Elwing, thank you again for participating with Team pH Awareness Month again this year. This is like a couple years for you now. We just love having you back, especially on this topic, something that I think has people thinking, should I, can I, where do I start?
Thank you for having me. I love this organization. You guys do such wonderful work. This is such a beautiful program, and I am just delighted to be here. And I'm going to talk about a good but also difficult topic of exercise. And for those people in the audience that have had pulmonary hypertension for more than a short period of time, maybe 10 plus years, you might remember that this is what you were told to do when you were diagnosed. Get yourself a nice place to rest. But of course, that's not the answer. But that took us a while to figure out, because in the early stages of pulmonary hypertension, the medications were not as good as we have now. People were less well controlled, and they were more symptomatic when they were active. So now what do we want you to get into? One of these. Pick your favorite, pick your best color, get out there and move, because we know that movement is as powerful as our medications. And we know that our medications do amazing things for people. So what is exercise? It's activity, physical effort. It's to improve health and fitness. So it doesn't tell you that you have to run, that you have to go to the YMCA, that you have to do squats. No, it just tells you have to move. So movement is whatever works for you. And what do the guidelines say about exercise? Well, they strongly encourage it. And I'm going to tell you a little bit about the updates from the most recent guidelines from the European groups for cardiology and respiratory. So this is the latest and greatest. So if you take that big publication and you search for exercise, you find it 186 times. Why? Because we care about it. We want people to be able to move more. We use it to measure how well our drugs work, and we use it as a metric of outcomes, and we use it for our studies. So very important part of pulmonary hypertension is movement. Okay, so what did they say? These are the Europeans, but we agree with them that exercise is important. And it's the first thing they talk about in general measures. So if you go back to 2015, they said exercise safely, basically. Be active within symptom limits. But then in the most recent guidelines, 2022, they said, well, we have more data. And we can say clearly that exercise benefits pulmonary hypertension patients. So what kind of data is that? Well, if you see here, all of the recommendations that they say for general measures like psychosocial support, vaccinations, diuretic treatment, what do they give exercise? 1A. That means the gold star. They say this is supported by data. And what is that data? Well, it's a group of studies that compared people who exercised to those who did not with pulmonary hypertension, showing that exercise helped above medications. Now, this is a consensus statement. So this is when a group of experts get together and say, what do we have to say about exercise in pulmonary hypertension? As I said, 20 years ago, it would have said, get that recliner. Now it says, specialized exercise training in patients with pulmonary hypertension appears to be effective, cost efficient, and safe. But put more money to it and convince your politicians it's important. That's the Europeans, what they said in that statement. All right. So where do we get the information that it's safe and effective? Well, there's multiple small studies, but I'm going to mention a couple that are really important. Now, this is, again, from Europe, published 2016, so not very long ago, looking at 78 patients. They were pretty sick. They had a lot of symptoms. They are functional class 3 and 4. They had either pulmonary arterial hypertension or chronic blood clots, and they exercised them for 15 weeks. So not a huge amount of time. Exercising low level, not getting out there and doing marathons. low-level exercise, 4 to 7 days a week. And at the end, those people who did the exercise training had better exercise capacity. In addition to that, their hearts were working better. At rest and with exercise, they could walk further on their walk distance or 6-minute marathon, many of our patients refer to. Their quality of life improved and their overall exercise capacity was better. So very impactful. This is on top of medicines. This is not in place of medicines, but on top of medicines. But you're like, that's a tiny little study, not very many people. Well, they did another study in Europe that they looked at 10 countries, 11 centers, and this is still small numbers, but pulmonary arterial hypertension is rare. They had 58 people they put in the training program, and 58 they did normal, just routine care. And they actually took them into the hospital for 25 days and did pretty intensive low-level exercise. And then they went home and walked and were exercising further. And what happened? At the end, their walk distance increased by about 100 feet, which is a big deal. This is what we look for in medicines. What else happened? Their quality of life improved. Their exercise, when they did the cardiopulmonary exercise test, which many of you are familiar with, when you get on a bike and they measure your air gases and they look at your exercise capacity, that improved. And their functional capacity, where we look at how functional you are on a daily basis, that also improved. And they said, this is safe and we need to do this for our PH patients. So how can you make this happen? Well, you got to ask your doc or your nurse practitioner, your advanced care provider, and really ask, what are my options? What will my insurance pay for? What can I have access to? And it could be through your insurance. There's a program like Silver Sneakers, or you might be a candidate for cardiac or pulmonary rehab, where you go somewhere and they train you and they teach you about exercise and nutrition and goals of outcomes in terms of your activity level. Or you might be able to access a home-based program. And there are those around the country that they can do exercise training remotely, which has been effective for many patients. But you're like, well, I already did that, or it doesn't work for me, or I'm 100 miles away from a program. What can I do? Movement, whatever that might be. There are a lot of low-level fitness apps which may help, and just getting out there and walking. And for those people who start walking when they are first diagnosed, don't go by yourself. You don't want to get really short of breath and then get really scared because you're like, oh my gosh, what do I do now? You want to have a buddy. You want to have a plan. You're not going to go that far. You're going to come back and you're going to see how you do over time, increasing over multiple weeks to months. And what does that do for you? Not only gets your body moving, but actually has been shown to reduce depression, improve positive outlook on the world, and get you in nature, which is always a good bonus. So in conclusion, exercise is good for all of us, especially when you have a heart and lung condition where it really can help you be able to be more functional. We want to exercise the heart and the lungs, and we want to do low-level exercise. This is not slam it in the gym. This is slowly increasing to the point that you're really comfortable. And you might get up to a high level in intensity exercise, but slowly and carefully. And you really want to ask your provider, what options do I have? And what can I do to make myself more active and more fit? So thank you guys for listening. I hope you enjoyed that. And I'll answer questions about that at the end.
Thank you so much, Dr. Elwing. As always, it was a pleasure having you with us. For our next topic, I'm pleased to introduce Susie McDevitt, who is a nurse practitioner at the University of Michigan Health System in Ann Arbor. Susie, thank you for your time tonight to talk about risk stratification.
Thank you so much. And I hope you all have heard a little bit about pulmonary hypertension risk stratification. It's a newer area for all of us as practitioners, and I'm joining you from sunny Ann Arbor, Michigan. You can see my background there. We have 3 patients from Ann Arbor with us tonight. I'm excited about that. So risk stratification, it really is about our goals for our medicines and our medical therapy. We have many goals for medical therapy in pulmonary hypertension. we want to definitely improve hemodynamics. That means the numbers on your right heart catheterization. We want you to have fewer and less severe symptoms, pulmonary, shortness of breath and fatigue. We want you to be able to have a better exercise capacity, to be able to do more and feel better. We want your quality of life to be improved. We want to prevent worsening like hospitalization, and we certainly want to improve survival. And it's risk assessment has really helped us be able to do this in a much more robust fashion. So risk scores in general, there are very many risk health conditions that have risk scores today. So risk scores in general support risk stratification. Risk stratification means putting patients into categories, and this is done systematically. It's based on a patient's health status and a combination of clinical factors. These risk scores help identify patients that may benefit from close follow-up or more treatment. So risk assessment in PAH, why do we do it? So first I want to remind you that risk assessment is only validated right now in group 1 pulmonary arterial hypertension, which was reviewed earlier, the groups. And why do we do it? We do it to measure the severity of the pulmonary hypertension. How advanced is the patient's disease? We do it to monitor for disease progression. We want to know if there's any subtle changes, subtle worsening going on. We would want to know that right away. And we use it to guide our medication recommendations and decisions. And I love this quote. Anybody who knows me knows I love this quote. Regular multifactorial risk assessment may lead to the best possible outcome for each patient. And that is ultimately our goal, for each one of you to have the best possible outcome. So risk assessment, how do we do it and when do we do it? So there are many risk tools and calculators available today. I'm going to show you a couple of those. These tools include a lot of your pulmonary hypertension testing. Some of them have a couple echo findings, echo parameters, things that we measure on your right heart catheterization, your 6-minute walk distance, your functional class, which means how symptomatic you are, how short of breath you are, your BNP or NT-BNP level, your laboratory level. And you'll see that these risk tools have traffic light colors, and these represent our different risk groups. So low risk is green. Green means go, right? Intermediate risk is yellow. That means kind of caution. And high risk is red. That's our high risk group that we're a little more concerned about. So we have the traffic light colors, and when we do it, we do risk evaluation should be done at the time of your diagnosis and every 3 to 6 months in patients with pulmonary hypertension. And just to show you a couple examples of some of the calculators, these are online calculators. The one on the left is called our Reveal 2.0 calculator. It's a little more comprehensive. It has 11 different variables that we plug in, and you can see the colors there, the green, yellow, and red. On the right, that is the Reveal Light 2 calculator, and it has 6 variables. So that one's a little bit more simple to use in the clinic. Here's another example of what we call the ESC-ERS tool, and this is the European one. You've seen references to this before, and from Dr. Elwing's presentation, the European Society of Cardiology and European Respiratory Society. And this is a more comprehensive risk tool that stratifies patients into low risk, intermediate risk, and high risk again, with predictions of maybe how well that patient will do within the next 1 year. And down below at the bottom of the slide, you can see we're now evolving into we call it sort of an expanded traffic light. We have a 4-strata risk score now that has low risk in green, intermediate low risk in yellow, intermediate high risk in orange, and the high risk in red. And that's because we've found that all patients in the yellow and the middle intermediate risk were not the same. So we wanted to further stratify and categorize those into separate categories, so we really know which patients are at higher risk and which patients are at lower risk and how to better manage them. And here's an example for you of an actual patient we're taking care of now using this Reveal 2.0 risk calculator. You can see how simple it is. The first thing, you enter the type of pulmonary hypertension that the patient has. This patient has lupus. So this patient has what we would call a connective tissue disease associated pulmonary hypertension. The patient is not a male. The renal function we plug in their functional class, which is functional class 3, their top number of their blood pressure reading, their heart rate, if they were hospitalized in the last 6 months, their 6-minute walk distance, their NT-proBNP laboratory value, and a couple echo findings, their PFT findings, breathing test, and then a couple of their right heart catheterization findings. And you can see that this patient's risk score at the bottom is an 8. So that patient is deemed intermediate risk by this risk calculator. And I wanted to just show you that the risk evaluation is now part of our treatment algorithm. And if we just look at kind of where the 3 red arrows here on the top, of course, you're all going to have your diagnosis confirmed at a pulmonary hypertension center, hopefully, right? So your diagnosis is confirmed at a center, and then you have your first risk evaluation right at time of diagnosis. If your risk is deemed low or intermediate, then you would be recommended to go on these certain medications. Often it's 2 oral medications, the ERAs and the PDE5 inhibitor. If you are deemed high risk at your first risk evaluation, you would be recommended to go on an ERA and PDE5, both orals, plus one of the pump medications, intravenous or subcutaneous. And then you will have regular follow-up risk assessments, as we said, every 3 months. And if your risk is deemed low, we'll continue that therapy. If your risk is deemed intermediate, high, or high, then your practitioners would possibly escalate therapy or increase doses of therapy, things that we can continue to add medical therapy so that we can get you to a better risk status. And last slide, the overall treatment goal is really to achieve this low risk status. We know that low risk status is associated with a better exercise capacity, with improved quality of life, with improved right ventricular function, and overall a low mortality risk. So thank you.
Thank you so much, Susie. I definitely have some questions that I myself will be putting in the Q&A. So really appreciate your time tonight. This next topic is another one that we receive questions about frequently here at Team PH. It's crucial to take some time to educate yourself on this topic. I am happy to introduce pulmonary vascular disease nurse Denise Lewis, who's out in DC, to share with us some tips and tools for dealing with PH emergencies. Denise, thank you for being here. I know this topic was super hot when you spoke to our support group last year.
Thank you for having me again. So I'm just going to talk briefly about PH emergencies, which we know happen. We don't like them, but they happen. So first thing is, if you have an IV catheter because you're on an IV medication and you have a pump that is malfunctioning, you always have a backup pump. If you have tried that backup pump and it's not working and you need to come into the ER, when you call EMS and they come to get you, they need to start an IV line and immediately hook up your medication, because we do not want that medication to stop. If it's a situation where you're close to the hospital and you bring yourself in, or your caregiver brings you in, make sure when you get to the ER, they start an IV so you can get your medication hooked up. That is an emergency. No matter what hospital it is you go to, have them reach out to your PH center. If it's an outside hospital, have the after hours number, the on-call number, whoever it is, but make sure if it's an outside hospital for them to reach out. If they don't, then you reach out to us. You know how to reach us. If your IV line comes out, there's a leak, there's a crack, any of those things, you need to come to the emergency room. If you are passing out, then you need to come in. You can call us as well and let us know you're coming or where you're going. If you get to a point where you're coughing up blood, things like that are emergency. So please don't hesitate to come in. There are some things that happen that aren't so much an emergency, but they're an urgency. Like we discussed, the swelling. If you're taking your diuretics, you've been watching your sodium intake, your fluid intake, you're still retaining fluid, then give us a call immediately so we can come up with a plan. to either directly admit you to do IV diuresis or try to add in additional diuretics or change your medications up. If you have fever, if you're starting to have issues at your cath site where you see redness, tenderness, anything like that, call us immediately. Anytime you go to the hospital, whether it's your PH center hospital, outside hospital, please take your medications with you. Because we know what happens when you get to outside hospitals that don't have these meds, they don't give them to you. And sometimes there can be a delay, even at your own center. So always take your medications with you. And if you have to travel, or if you are having some kind of elective surgery, or anything outside of just normal day-to-day, talk to your team. That's what we're here for. We're walking this journey with you. So we will come up with a plan to get you where you need to go. I might tell you to call Julia because she's got lots of advice. But talk to your team. We'll come up with a plan to make sure you know how to reach someone wherever you're going, and to talk to your other doctors when it comes to having surgery, because that's very, very important, and that can turn into a really bad emergency. So just a few reminders, always have your backup pumps if you're on pumps. Make sure you have your medication list. Keep all your meds together and somewhere close, because when emergencies happen and you rush out the door and somebody may have to come back home to get your meds, you don't want to have to say, hey, can you get my so-and-so off of the kitchen counter and this from out the bathroom. Try to keep them together as much as possible so you can say, hey, can you grab my bag of meds off the second shelf? And they can grab them and come on back. So, and always call us. So that's it. I'm happy to take questions, and it's a lot to discuss, but I try to squeeze it in as quick as I could.
Thank you so much. For our viewers, Denise led an hour-long discussion on this for us last year. You can find the recording of that on our YouTube channel, and our handle for that is @TeamPHHope. So really encourage you to go give that a watch. Denise, thank you again. It's always good to see you. All right, next we're going to go over social determinants of health. I'm happy to introduce Dr. Lena Melendres-Grove, who is out in Albuquerque. Dr. Melendres-Grove, welcome back. Thank you for being here with Team PH again for another PH Awareness Month.
Thank you guys for having me. I echo what all of my colleagues have said previously, which this is an unbelievable group who bring together some of the best and the brightest in the field. And I learned so much for being on and listening to them talk about some of the most important aspects of pulmonary hypertension. I'm tremendously excited to be able to talk about the factors that influence health outcomes. As Katie mentioned, I'm Lana Melendres, and I'm the Pulmonary Hypertension Medical Director at the University of New Mexico. And I'm going to just talk a bit about sort of the cycle that I think for all of us has to work well. What we're looking for is trying to create an equitable environment for every person. And frequently, that can't happen unless all of these pieces are really being improved upon at the same time. So when we think about social determinants, many times people talk about the social conditions, but the structural conditions play into what our social conditions are. And then when you look at it, we talk about policies and laws, and if we changed those, but we're not able to really address any of that until we start collecting the data and being able to do the surveillance to understand where we are in terms of our needs. And with that data, then being able to evaluate and create and build evidence to be in an area we can partner and collaborate with those in our communities and start to engage beyond just individuals, and then create the infrastructure and capacity for us to once again affect laws and policies. And one of the things that I find helpful is a slide like this, where in PH, we always talk about our 5 groups of pulmonary hypertension. And so I thought it might be nice to think about sort of these 5 different blocks that we have to consider when talking about social determinants of health. And first, we often think of money, right? We think of finances, we think of economic stability, and that individuals who may be in a position that is a significant stressor for them, that the rest of their life then plays into what their capacity is. But that also plays into what education and access they had. What was the quality of that education? We know that is tremendously different even across the United States. And so to be able to say we can provide the education and access, not just in school, but what's the education and level of understanding that a patient who's sitting in front of us in clinic is able to understand and interpret. And then when they are receiving that health care, everyone on the call today very much so is speaking from a place of having sort of these comprehensive care centers. But we know that in many of our rural communities, that healthcare access is less than what we would like it to be, and often the quality is not at the standard that we would expect. And then within even our own neighborhoods, what is our environment? Is it safe to go outside? Is it safe to exercise? I know that Jean Owing had talked a lot about exercise and the importance of that, but how are we able to access that? Are there, community centers nearby, or is there a means to be able to do that? And then just within our own homes, what are our social networks and our community to be able to support us and help us in our journeys? Every piece of that will affect an individual's ability to have improved outcomes along the way. And so I break it down as simply as I possibly can. And for me, it really is looking at all these different people, but then we have to look at the person that is in front of us on any given day and what their needs are. When we talk about that income and somebody's financial stability plays into what environment they have. Is there safe housing? What is their education? And when we look from a slide from 2020, we can see that in many parts of the United States, there were patients that were living upwards at 40 to 44% of them below the poverty line. So we talked about nutrition, reading labels, being able to make sure that the foods that we are and our patients are eating are going to be in that low sodium, less than 2,000 milligrams. But when you only have the money to buy what you can buy, to be able to say, well, now it has to be something different because you need that for your ongoing health, but they need that to pay the bills. So it becomes a true struggle for everybody out there, and to have those considerations. Many people don't have the ability to cook on their own anymore, and so having to be able to rely on others for that. The other piece that is very near and dear to my heart is just sort of the cultural and language and race behind our patients that we're caring for. And in New Mexico and my neighboring states, we know that our Native American populations, are in a higher percentage, as well as our Hispanic populations. And one of the studies that was performed looked at how patients didn't do as well if they had a provider that wasn't able to speak the same language as them. They didn't feel as comfortable sharing sensitive information. These are pieces of the puzzle that we often don't think about, but really will affect somebody's ability to do well. Another piece of it is going more into sort of that race and ethnicity, and knowing that certain individuals, often because of lack of access to healthcare, may present later in their disease process, or may present and not be able to receive the same types of medications compared to other ethnicities. And so being cognizant and thoughtful about that as providers, making sure that we are working to treat all our patients equitably. And for me, I know that I'm running short on time, but a consideration of all of these pieces for each patient, to individualize their care and their needs, why our social workers and all of the staffing that we have supporting us as providers really look into that, so that hopefully our outcomes of our patients continue to improve as we continue to find a way to equitably distribute healthcare and therapies for everybody. So I want to thank you all so much. I really appreciate having the opportunity to be here.
Thank you again. This is a topic that is increasingly, we are getting more and more requests to talk about this. So really appreciate your time tonight. So last but certainly not least, I'm honored to welcome 2022's Team PH Research Award winner, Dr. Arun Jose, to touch on some of his research findings for his research titled Circulating Gut-Derived Metabolites as Markers of Disease Severity in PAH.
Thank you so much for the opportunity to speak briefly about my work and an update on it. And again, thank you for the Team Phenomenal Hope for supporting this work. I'm going to talk very briefly about an update on this project titled Circulating Gut-Derived Metabolites as Markers of Disease Severity in PH, but really we're talking a little bit about the link between the gut microbiome, the circulating metabolome, and pH. And so I chose the somewhat playful title, You Are What You Eat. So a little bit of background. It turns out there's a lot of microbes that live in our gut, about the same number of microorganisms that live in your gut as there are cells in your body. So as you might expect, they do a lot. They can affect your health directly. They have a lot of role in turning what you eat into stuff that ends up affecting your body and physiology. So they ferment dietary fiber that you intake into usable compounds. They synthesize important vitamins that your body needs. They produce a lot of hormones and metabolites, circulating products that enter your bloodstream and affect, distal organs. Also, as it turns out, because there are so many of them and they do so much, they're also linked pretty closely to human disease. In the field of cardiovascular and pulmonary vascular disease, they are linked to both heart failure and also pulmonary hypertension. Let's figure out what is the link between the gut microbiome, those organisms that live in your gut, the circulating metabolome, those things that they produce, and pH disease. So how bad is your pulmonary hypertension? And so in order to do that, what we did was we took some patients with pH. At the time of right heart catheterization, we got blood samples from them, and we got gut microbiome stool samples from them. We used the blood samples to identify compounds that were in the blood, circulating metabolites, the things that the gut microbiome produces. And we also used the stool sample to figure out what kind of microorganisms live there and what they do. And we linked those two to each other and also to pH disease severity to try and create this sort of multidimensional link. So ultimately, the hope was that we could identify gut microbiome signature, represented here by this fun little bacteria, and also the metabolites that it produces and how those are linked to disease severity in pulmonary hypertension. What is the ultimate aim here? This is a brief slide on some data. I'm not going to be too heavy with it because it gets a little dense, but this is just one of the representative metabolites that we found, in this case, glycerophosphocholene, which is a precursor to choline metabolism. And on the bottom, you see markers of pulmonary hypertension disease severity, how high the pressure is, how high the resistance is. And what you can see is a pretty nice relationship with the amount of metabolite in the blood and the disease severity, suggesting that this metabolite might be correlated with disease severity in PAH. I highlight this in particular from our prelim data just because it turns out that an older study looked at metabolites in people getting right heart catheterization across the pulmonary circulation, and they found a similar relationship between glycerophosphocholene and level of pulmonary hypertension. And then an analysis of the pulmonary hypertension biorepository in the United Kingdom also found a similar relationship where the glycerophosphocholene metabolites were associated with whether or not you had pulmonary hypertension. So suggesting that this might be an important pathway that might be produced by the gut microbiome that could be associated with disease severity and pulmonary hypertension. ultimately, the question comes down to how can we use this for our patients? So in theory, if we were to establish this link between a gut microbiome, what it produces in terms of the metabolome, and disease severity and pulmonary hypertension, we might be able to disrupt this pathway for benefit in our patients. For example, if we know what gut microbiome species exist, and we have metabolites, we might be able to augment the gut microbiome either with antibiotics or probiotics, disrupting that part of the pathway. Or alternatively, if we know what circular metabolites are associated with pulmonary hypertension disease severity, we could alter the levels of those metabolites using an anti-metabolite pill or by dietary interventions that favor or disfavor a given metabolite. Ultimately, disrupting this pathway might result in less pulmonary hypertension disease severity, potentially resulting also in improved survival and maybe some reverse vascular remodeling, which would be a completely novel therapeutic for our patients and an additional option that might have a lot of benefit with not a whole lot of side effects. So I'm going to leave it at that, but thank you so much for giving the opportunity to provide an update on my work.
Yes, and thank you so much for taking the time tonight to do so. We at Team PH are so proud to be able to contribute to furthering scientific research in the field, and I know that we really look forward to hearing more about your findings in the future. Thank you so much.
No, thank you. Appreciate it.
Yeah, so we've gone over time tonight, which is okay. We do have some questions that we can go over in the Q&A. We don't have a ton of time, so I'm just going to briefly go over a few that I see here. So presenters, if you could help me out, this first one I have is there a difference between the fluid that accumulates in the lower extremities from the fluid that accumulates around your heart? Thank you. I think this one might be for Susie.
Martha.
Or Martha? Yeah. Yeah, Martha.
Well, Susie might have a better answer, but I believe the answer is that it's the same. The fluid. Yes. When you're retaining fluid, it's just all over your body. And sometimes you see it more in the legs because of gravity makes it, go down to the legs, but same fluid.
Thank you.
Welcome.
Another question we have. What if the risk level does not correlate with the patient's actual exercise tolerance, saturation, and recovery?
Okay, let me take that one, risk. So I would say risk scores are not perfect, you guys. This is a whole new field for us. Risk scores are evolving. You saw that our traffic light now has orange. We have 4 colors, and we're sort of moving to even more refined risk evaluation. So risk scores aren't perfect. There are times that we see kind of a disconnect between how we think the patient's doing and the risk score that we get. So that's a conversation definitely to have with your provider, but I can give a couple examples of that. So sometimes your hall walk is impacted by other things, right? Not just your pulmonary hypertension and how your right ventricle is doing. Your hall walk can be impacted by your sore knee and your hip pain and your back pain and all the other things that we all have. So if your hall walk is lower and we plug that into the risk score, it can make your risk score look worse. Does that make sense? Other things, sometimes your shortness of breath is impacted by other things besides your pulmonary hypertension. Your blood pressure could be low for a different reason. Your kidney function could be off for a different reason. So when we plug that in the calculator, it's not all related to your pulmonary hypertension, if that makes sense, but we're still trying to do the best we can to get everybody in the green zone if we can. So hopefully that answers that question.
Thank you. And it looks like we have another one for risk assessment. Is a risk assessment done for PH patients or PAH patients only? If so, why?
Sure. Great question. So right now, risk assessment is only studied and validated for group 1 pulmonary arterial hypertension. Okay, so that was the groups that we went over. So that's the idiopathic, the heritable, the associated conditions like the connective tissue diseases, drugs and toxins, all of that. So it's validated and studied in large groups of group 1 pulmonary arterial hypertension patients. Just like our medications are studied, we have much more work in group 1 than we do in group 2, 3, 4 and 5. And so we're really trying to expand our work in all the areas in the other groups of pulmonary hypertension. And they will be working more into risk assessment in the other groups. For now, we really, for the evidence and the guidelines, we should be using it in group 1, pulmonary arterial hypertension. If that makes sense.
Thank you. Well, it looks like a large majority of the questions were already answered via the Q&A. We were able to type answers back already. Any other questions that we had, we will take down and try to get those answers out to you tomorrow after this webinar. With that, we're going to go ahead and conclude Q&A and the Research Town Hall. Again, on behalf of Team PH and our board of directors, thank you all. Thank you, our presenters, our supporters, our sponsors, and to all of you who tuned in. We will definitely share this recording on our YouTube channel, which the QR code on the scrolling slides will take you to. Thanks again. Have a good night, everyone.